Good. Thank you. Let me get my timer going so I'll make sure I don't take too long here. So good. All right. Well, thank you so much for having me in that introduction. As you said, I'm Justin. I'm one of the sports medicine physicians, non-surgical sports medicine physicians within our family medicine department. Um, and knee arthritis is something, like I said, we take care of a lot, and really enjoy it. And I hope this talk is informative. Kind of just go over the basics about what it is, and then lots of different things that you can do at home. This will not be all encompassing, but I'm trying to hit up a lot of things that I think people can certainly do at home to manage as best they can. Because again, I look at knee arthritis kind of like, as a sports doc, just like other people may look at high blood pressure, high cholesterol, things you kind of have to manage long term. And this is something that we kind of look at as a long term thing to try to manage as best we can. So I hope this is good and informative for everybody. Couple disclosures. I have nothing financially. Nobody's paying me to do this talk. I am not advocating for any product that may get presented. So there's going to be a number of different products, different brands, et cetera, that are displayed on my presentation today. But I'm certainly not advocating for anyone specifically. Regarding some of the things that we're going to go over, like I said, Voltaire and Gel already came up earlier, just in brief discussion. But any of the medication things or supplements that I'll go over, please talk to your doctor about any kind of changes or additions. Or I guess I should include the pharmacists too. Pharmacists are pretty knowledgeable. And my last disclosure is I really enjoy managing knee arthritis. So my thought, as a sports medicine doctor, I think people, think like, oh, well, he just wants to take care of, the UNC football players or basketball players or professional athletes, and that's not true. I mean, those kind of patients are fun to take care of, but like I said, in my mind, anybody who shows up into my clinic is an athlete for as long as they want to be, is how much they want to be. So I want to help people achieve their goals and be as active as they can with whatever they're trying to do. Secondly, I was just going to say, feel free to interrupt with questions. It's tricky as the speaker when you're sharing your screen to be able to see if there are questions that people type into the chat. I don't even, maybe people, I think there's like a hand raise function. I don't know how well that works on my end. Maybe there's, I don't know, but feel free to interrupt.
I'll keep track of if there are any chats and share.
Perfect.
Those. Yeah, thank you.
Thank you. Because like I said, I do have a, kind of a template for the talk, but again, I'm happy to answer questions. I'm certainly going to leave plenty of time for questions at the end, but again, if something pops up, people want to ask it, please, type in the chat or interrupt me. I don't care. I won't be offended. So kind of what we're going to cover today is kind of the basic review of knee arthritis, kind of arthritis in general with a focus on the knee. And then kind of go over just, again, a variety of things that you all can do on your own, which kind of consist of, different kind of home exercises, different, modes and modalities from a exercise standpoint itself, things you can do to kind of treat, modality wise, like ice heat, those kind of things. Just briefly review bracing, knee sleeves, etc. And then spend a little time talking about different over-the-counter medications. Some of you may already be aware of some of these, but some of them you may not. And then a variety of different supplements, just to kind of give an overview of kind of some things that you can certainly do on your own at home. And I didn't put it on here, but I'm going to wrap up with some, if all this stuff doesn't seem to work or be doing a job managing your pain and helping with your function, just briefly kind of go over, if you do seek care from a doctor, kind of what the different kind of options are there in that regard. But again, most of this is going to be focused on kind of home management for you all. All right, so very simply, what's arthritis? What's osteoarthritis, right? So this, I think in the simplest terms, is when you get breakdown of joint cartilage between bones. All right, so all of our bones, when they come together at a joint, the ends of those bones are lined with something called cartilage. And when that cartilage starts to degenerate, break down, thin, etc., that then kind of eventually over time leads to narrowing of the joint. Eventually you can kind of get bone rubbing on bone. there's a lot more factors that go on than that. But I think that's kind of the simplest way to kind of think about it, is that breakdown of that cartilage, which the cartilage allows for kind of smooth movement of the joint, so that, like I said, your bones aren't rubbing against each other. What are your typical, things that you feel, right? Certainly pain in that joint, usually more of an achy pain. Certainly there's times when it can flare if step funny, twist your knee funny, come down from a step or a jump, and you can certainly get sharp pain as well. But I think most of the time it's kind of more of a deep kind of achy joint pain. Certainly can be tender around that joint when you push. I think stiffness is a common one too. I usually tell patients that with typical osteoarthritis, particularly talking about the knee, right? You can have morning stiffness. Usually you can work it out on your own for a little while. One of the kind of diagnostic criteria is kind of, morning stiffness that lasts less than 30 minutes, because a common question I get among patients, I don't know if it's a common question, how do you know if this is, regular osteoarthritis versus, is someone, can I have somebody mute? I don't know who that is.
Yeah, so someone, if everyone can mute themselves so we can be able to hear.
Can everybody please mute?
I'm trying to mute.
Yeah, so Tammy, can you mute yourself, please? Yeah, thank you.
Oh, there we go. Thank you so much. So I was saying, like I said, I get a lot of questions about how do you know what's regular osteoarthritis versus something else, like an autoimmune form, like a rheumatoid or lupus, psoriatic arthritis, et cetera. And typically with those, particularly when you're talking about like something like rheumatoid arthritis, that morning stiffness is going to be much more prolonged in the morning. Usually it's greater than 60 minutes. That kind of affects the joint. And so usually with just regular arthritis, it can be pretty stiff in the morning, but usually as you move around, it kind of loosens up, and it's usually less than about 30 minutes max. Some people it's 5, 10, 15 minutes, something like that. And then I think, and then the stiffness too can obviously occur if you kind of do something like prolonged sitting, and then you kind of get up to move around, you certainly feel stiff as well. And then I think swelling as well. Some people swell, some people don't. I think there's kind of different. I think we're starting to figure out there's kind of different kind of subtypes of osteoarthritis, particularly when it comes to the knee. Some people do swell quite a bit, and then some people don't. They have more kind of what I call a dry knee arthritis. They don't swell a lot, but some people certainly can swell as well. Again, we're talking about the knee today. The knee is the most commonly affected joint, but you can have other joints that are affected. And the hands are very common, especially kind of at the base of the thumb, or just some of the kind of smaller joints on your fingers, kind of close to your fingernails. And the hips are kind of a fairly common one too, but the knee is by far the most kind of common one. Okay, hold on, let me see if I can advance. There we go. Again, so this is kind of a simple kind of picture representation, right? So at the end of here's your knee joint, here's your thigh bone up top, here's your shin bone below. You kind of see this shiny kind of white stuff on the end of the thigh bone. That's what your cartilage looks like. So it kind of just allows for kind of smooth gliding of the joint whenever when you're bending your knee, walking, etc. And then on the right side, this is kind of what arthritis looks like, right? That cartilage has started to wither away and started to degenerate, degrade, whatever you want to call it. And again, when that happens for a prolonged period of time, then you can actually start to get some underlying changes to the bone as well. And again, your joint can become more and more narrow. That's when you kind of start getting quote unquote bone arthritis, and it's just very, very painful when those bones kind of rub together. All right, so again, this is a very kind of simple way to kind of show kind of what happens. This next slide, don't have to memorize this. Okay, this is the kind of slide they show at kind of our national conferences for sports medicine, orthopedics, and stuff. And it just shows that I think the reason I show this is that there's a lot of things that we can't see on an exam or an X-ray or an MRI or anything like that. There's a lot of things that go on a much smaller kind of chemical, cellular level. All these different inflammatory mediators, cells, enzymes, peptides. Again, there's a whole host of things that all kind of interconnect to kind of keep your joint at this kind of happy, in a happy medium, right? And so again, very, very complex, all the kind of underlying things that can happen with the knee joint, or any arthritis joint. Again, kind of focus on the knee today. So again, it's really, really complicated, but I just kind of show this that again, there's a lot going on here. And this is kind of knowing some of this varying. I don't know and understand all these different things either. A few of these things I recognize, but when we talk about some of these we'll briefly touch on this later. We talk about these fancy treatments when you're talking about like, quote unquote regenerative medicine, stem cell injections. All those things are trying to hit this, stuff at this level, right? Trying to change the different inflammatory mediators, cells, et cetera, et cetera. But again, just show you how complicated it really is, and where all the science and research is hopefully going forward in the future to kind of figure out how best to help people. So kind of just lastly, kind of finish up on what it is, sorry, I got the timer back up here. What are the, I'll start with saying, the bottom, I said, what's the actual cause? I think we always say osteoarthritis, whether it's the knee or hip or fingers or whatever, we say it's kind of wear and tear. I don't know that that's really true. I don't know if that's really been proven. I think it's what we say because it's easy and convenient. But if you have someone who's, the same age, same weight, same kind of activity level, you can have one person that has a perfectly fine knee, and then some person of equal caliber that maybe has pretty significant knee arthritis. And why is that? I don't think we always know. There's these risk factors that I'll go over and above, but again, I think the actual underlying cause of knee arthritis in general, but knee arthritis specifically, I don't think we 100% know, because I have so many patients that show up in clinic and ask me when they start to get knee arthritis, well, how do I keep this from getting worse? And it's not an easy question to answer, because there's not a perfect answer, and all we can do is try to manage it. Certainly reverse, there's no reversing that we know, but try to keep it from getting worse, and we can go over things. But again, part of it's because we don't 100% understand the actual underlying cause in a lot of cases. What we do know is that there are certain risk factors that put people at higher risk of getting this. For the knee specifically, we know excess weight. The heavier you are, the more likely it is that you will develop it, just because it's more stress on your knee. As you age, we know it's more common, whether that's age alone or if there's other factors that go along with getting older that are related. We don't know for sure, but we do know it is more common as you get older. Certainly a prior injury or prior surgery puts you at risk, right? So if you're, in teenager or early 20s, you're playing, soccer or tennis or football, basketball, or something like that, and you twist your knee, hear a big pop, and tear your ACL, which is a big stabilizing ligament in the middle of your knee joint. We know that puts you probably at higher risk, even if you get the surgery to reconstruct it. Or if you have a break, you got a fracture or a dislocation, like I said, your kneecap dislocates, or God forbid you have a true knee dislocation where your thigh bone and shin bone completely tear apart. Those are both obviously risk factors for getting arthritis later. And the reason we think is because when those things happen, you, as a part of that, you injure the underlying cartilage, and it's just hard for it to heal completely. I think another big common one is a prior surgery for your meniscus. So if you tear your meniscus sometime earlier in life, the classic thing to do for it is to just kind of cut out that torn piece. That's called a meniscectomy, which if you need to do it, you do it. The problem is we know that once that meniscus is gone, it doesn't regrow. And now you've got, I'll back up a slide or two just to show you guys on this slide again here, the meniscus, you got the cartilage on the end of the thigh bone, the cartilage, which is this first kind of thin white line here on the shin bone, but there's this kind of thicker, kind of rubber kind of thing called your meniscus. If you guys can see that right through here, that's a little highlighted in pink. But that's another kind of shock absorber deep in the knee that's really important when you're bearing weight and twisting and turning and things like that. But it's a common source of injury that can happen in the knee. And again, if you get it cut out, well, then that's just one less piece of kind of cushion in your knee, and so it's more common. It's not inevitable. Maybe it is, maybe it is. I don't think we know for sure, but we know it does greatly increase your risk of getting arthritis in that area where your meniscus gets cut out. I actually had a guy in clinic probably last week or the week before, I can't remember who. Great guy, late 40s, like 48, 49. who tore his meniscus in college at 19, had his meniscus cut out, did great for like almost 30 years, and then noticed over the past year or two that every time he go out and play soccer, his knee would, blow up with swelling and pain. He'd have to take a couple weeks off and finally cool off. He'd go out and same thing would happen again. And, he could run okay with not too much pain. Went to physical therapy and this wasn't quite getting better. Kind of had a bumpy road and finally got in to see me. And sure enough, he told me I had a torn piece of meniscus that got cut out when I was 19, get the x-ray. And sure enough, on that side of the knee where he has, meniscus kind of taken out, or the piece of torn meniscus taken out, he had developed a pretty significant amount of arthritis. So we kind of just had to counsel him going forward what to do from an activity standpoint to kind of lessen the chances that his knee was going to continue to give him problems. So last couple of things. So genetics, we know that genetics probably play a role. We don't know how exactly. We do know, I think it's probably more common in the hip, where people have, family members who've had a hip replacement when they're like, in their 50s or something. There's a higher chance that may happen to you too. But we think genetics probably play a role, but I don't think we fully understand why that is. So if knee arthritis runs in your family, and especially if people are having to get knee replacements earlier in their life, there may be a genetic component. But again, we don't know all the details. And then for whatever reason, females seem to have a higher incidence of osteoarthritis, particularly in the knee, than other patients, but we don't know 100% why that is, females more than males. All right, cool. So now what y'all really want to hear about, which is how do I deal with this? How do I take care of this at home? All right. And I think one of the simplest things that people can do is to do some basic home exercises to kind of strengthen their lower extremity in a number of ways. So I will say that this is a very simple home exercise program that I'm showing you all here. If you guys Google, home exercise program for knee arthritis, after this talk, there'll be tons of other things you can do. I think these four are very good and very simple things that just about anybody can do. So this first top left one is called a straight leg raise. All right, so all you're doing is you're kind of sitting or kind of leaning back like this patient. You've got your knee. Can somebody mute themselves, please? Someone mute themselves. Oh, muted. Okay, thank you. So first is just a straight leg raise. So you can get your affected leg fully kind of straight out and extended, and you count 1001, bringing your foot up, and then count 1002 coming back down, and that's one rep. And if you can do this, 10 to 15 times, maybe a couple times a day, does wonders to really strengthen up your quadricep muscles, kind of up here in your thigh. Those are really important because your muscles are kind of your what we call your secondary stabilizers for your knee, and so they provide a lot of good, really help to improve the function of your knee. So again, very simple thing that you can do to strengthen up those quad muscles and help out your knee pain and function. This upper right one is just called a knee slide. This is really good for kind of maintaining just range of motion, particularly if you're starting to lose range of motion and feeling very stiff. So you basically got both feet straight out, your affected knee. You can certainly do all these on both sides, but the affected knee, you can take it and you just kind of slide your foot back as far as you can go. So try to see if you can touch your foot or your shoe to your butt, and then go back out. If you're on like a hard floor, again, obviously you can put like a towel or something underneath your foot to kind of help slide it back and forth. But again, this is great to kind of just maintain that range of motion and help you regain range of motion if you're losing it or if you're feeling very stiff. The bottom left one here is called a sideline leg raise. What this does, so you lay on your side, and again, this is one I would do on both sides, regardless of which knee is affected. All you do is lay on your side and keep your leg straight, and again, take it up for 1001 and come down 1002, and that's one rep. And like I said, see if you can do 10 to 15 of those, and then do that a couple times a day. What that does is really strengthen up these outside hip muscles called your gluteus medius and minimus, which are really important for kind of helping to stabilize your core and your pelvis all this through here whenever you're walking, all right? Because when you walk, those muscles kind of keep you from kind of, kind of drifting side to side. And by having those nice and strong, and keeping your pelvis kind of stable, it kind of prevents you from putting excess, strain and forces on your knee in the wrong way. So again, this is a really important one to kind of, strengthen muscles up around your pelvis to kind of help downstream with your knee. And the last one here is just a basic kind of hamstring curl, right? And so what you're doing is you're just laying flat and thinking about bringing your foot in kind of as far as you can to touch your butt and kind of coming up 1001 and go down 1001. That's 1 rep, same thing, 10 to 15 times, once or twice a day. Helps to keep your hamstring stable, or hamstring strong. And also, again, good for keeping your knee nice and limber from a range of motion standpoint. Again, these are the 4 very, very simple things you can do. There are plenty of other ones out there, but I think this was just a good, simple program for anybody on this call can hopefully do. All right, so those are home exercises. What else is really important is just good old fashioned, regular exercise of some sort. Okay, I think some people who have knee arthritis, not everybody, but some people get kind of this fear avoidance behavior, and they don't want to move because they're worried it's going to hurt or make their knee worse. And we actually know a lot of time the opposite is true. I tell every patient, motion is lotion. All right, the more you move, the more your knee will feel better and stiff. That within reason, obviously. But bottom line is, do not be afraid to get regular exercise. It's going to be great for your overall health. Keeps your knee strong. Helps hopefully take off weight or keep weight off. Helps your cardiovascular health, etc. And I think the mode you choose is up to you. Again, I don't have knee arthritis, but out of all these things, my thing to do is run. I love running. That may not be an option for everybody, depending on your overall function or the severity of your knee arthritis. But I do want to just put out a plug that if you have some kind of mild to medium arthritis in your knee and your symptoms are a little annoying, but they're not terrible. We do know there's studies showing that with running does not necessarily make your arthritis worse, nor do we think it truly causes arthritis. We talk about this recreational running. So again, if you have some mild arthritis, don't be afraid to go out and jog for a couple miles. That is totally fine. And we know it doesn't necessarily make your knee arthritis worse. It may make your symptoms a little bit better. Other things you can do, again, simple things, stationary bike, great form of exercise. It's pretty easy on your joint, easy to do. This right here is your elliptical training. It's also there's different forms called an arc trainer. But again, another good one from a easy on your joint and really good cardiovascular workout. Strengthens up multiple different muscle groups and kind of keeps your knee nice and limber. We know that just going out for a good old-fashioned walk is also really good, right? And they've got different studies showing that land-based, physical therapy or land-based exercise programs are maybe just as good or safe as what I'm going to talk about next, which is swimming. So if you like to get out and walk and, like I said, getting sunlight and seeing nature, like I said, walking is just a great way to do that. And then I think swimming is another just classic things that I do recommend to patients because it's great for your overall health, and it's so easy on your knee. You get that buoyancy from the water that really can be takes pressure off the knee and allows you to get good exercise and get motion in the joint and just help your kind of overall kind of health and well-being and keeping off or taking off weight. All right, a couple of quick things. Like I said, other things, modalities. So again, there are other things that I could get into, but I think the most common things that kind of people ask about or want to know about is heat and ice. I will first off say that evidence for either one of these or both of these is lacking. We know, for instance, like if you sprain your ankle or something, that the first couple of days afterward, if you ice it, it probably helps decrease kind of some of the swelling. But after that, like we don't know how much this stuff really helps, from a long-term standpoint. What I do tell patients, if this does seem to help with your symptoms, meaning help how you feel, helps control your pain and helps your function, great, do it. In general, I recommend if you have pretty significant stiffness, heat tends to be better for that. And certainly before you go out and exercise or do some kind of activity, I think heat is really good to kind of help help with stiffness in the joints, warm up your muscles, etc. And then after exercise, or particularly if you have some swelling, then ice is better for that. But again, I think, any combination of these, whatever you find works for you, I think is totally reasonable. But this is typically what I recommend: heat for stiffness or before exercise, and then ice if you have some swelling or after you go out and move and exercise or do a lot of activity. All right. How about braces and sleeves, right? I get questions about this too. If you go on Amazon, because I did this the other day in preparation for this talk, because I wanted to know, like, well, what are people in the community, if they go searching, what are they seeing? And there's a bazillion different brands and models of, sleeves and braces and things like that. But I think in general they come in, a couple different flavors. For the most part, you've got kind of like your typical kind of knee sleeve, which you see here. Again, nothing fancy, usually pretty cheap, and very easy to use and put on. The best thing about this, or the best use of this, I think, is certainly, I'll tell patients, if you have some kind of issues with some recurrent swelling in the knee joint, that this is good to kind of help with a compression standpoint to keep the swelling down. I think it's also helpful for patients, especially during like the winter time when it's colder. This kind of having a sleeve on is a good way to kind of keep your knee a little bit warmer so it doesn't get stiff. And again, for some patients, I'll have them try a couple things in the office, or I'll have patients tell me I've tried a few things and what felt best to me was the sleeve. Even from a stability standpoint, they'll tell me my knee just felt a little more stable. It didn't feel like it was kind of moving or giving way as much. And I was like, okay, that's fine. But again, very simple, easy, cheap thing to try to see if it does help out with your symptoms in knee pain and function. A little bit more complicated is one in the middle is a hinged knee brace. Like I said, and to be clear, I'm not advocating for Don Joy. I just want to be very clear about that. They're a big brace company. They do a good job, but I'm not advocating for them. This is one of their simpler braces that you can get online. It's got this hinge on either side. And kind of what that does is, again, just, when you're walking, if you have some arthritis and maybe a little weakness in the knee or whatever, your knee can kind of, shift just subtly, as you bear weight. And so sometimes kind of having this hinge knee brace can kind of help with a little bit of stability in the knee and make you feel stable, less likely that's going to give out or you're going to fall, etc. I have some patients that like wearing this kind of all the time, and I have some patients that only use it when they're trying to be active, whether they're running or at the gym or still trying to do some, play some soccer or basketball or whatever. But another good option, I think this will be a little bit more expensive than the sleeve, but you can get some online pretty cheap. The most complicated one is one called an unloader brace. The reason I put this on here is that I did find this on when I looked on Amazon. This was an option that you could get online. I probably wouldn't recommend that. I'd probably recommend coming into our office to try to see if because it gets a little more complicated. But the idea here is if you've got a certain part of your knee joint that is more affected by arthritis than another side. For instance, here, this is the outside part of the knee. This is the inside part of the knee. So your outside part of your knee is more affected by the arthritis. That's where you get more of your pain. You have a little bit more loss of the joint space here. The idea is that you've got this kind of hinge on this side that you can actually kind of crank up and tighten up. And what it does is it puts pressure here. And the thought is if you push this way, it'll kind of help to, in theory, kind of open up this joint space and literally unload this part of your knee joint. So hence why it's called an unloader brace. And so, you again, looking online, you can't get this online. I would probably not recommend getting one online because I think these are a little more complicated from a fit standpoint and use. So I'd probably recommend if you're interested in something like this, we can let you try some on at the office, or if whatever we have in the office doesn't fit or doesn't feel right, we have a good relationship with our brace company, and they can kind of do it more of a custom one. So that's an unloader brace. So, all right. Okay, I'm sorry. So last couple slides. So kind of at home or over-the-counter medicines that you can use. So there was already an early discussion right when I got on about Voltaren gel. It's also called diclofenac gel. That you can rub on. Again, it's great because you can rub it right on. It works just like ibuprofen or Aleve or any other kind of anti-inflammatory, but much safer because again, it just mostly works at the site. I do have to tell you, a little bit does get taken up into your system. So doesn't just stay at the site that you put on. Some of this does get up in your bloodstream and can have some effects on other parts of your body, but not nearly to the degree like ibuprofen and naproxen when you start worrying about some side effects. But the downside here, it's great, it's over the counter. Like I said earlier, it used to be a prescription only, now it's over the counter. The only downside is you really make, to be effective, most patients have to do this usually like 3 to 4 times a day, which may not always be feasible. Again, you just got to kind of keep it on your mind or set a reminder or whatever, but it is great. Ibuprofen and naproxen, which is also called Aleve, again, very common, been around forever. Again, usually pretty effective for a lot of patients, not everybody, but pretty effective for most patients. Again, you do have to worry about, side effects like upsetting your stomach ulcers. If you use it long term, it does raise your risk of heart disease a little bit and kidney problems and high blood pressure. On the whole, like I said, if you use it kind of intermittently, they're both, for the most part, pretty safe. But again, talk to your doctor first. Tylenol or acetaminophen, another common one used. I don't think this, in my opinion, it doesn't work quite as good. And I think the literature, the research probably shows it doesn't work quite as good as things like ibuprofen, naproxen. But just because the research says that doesn't mean it won't work for you. I would say in general, it's probably safer as long as you're not taking too many. If you take too many of the Tylenol, this is what can hurt your liver. But if you're, if these 500 milligrams, if you do 500 milligrams, 3 or 4 times a day, that is not going to have an effect on your liver. And for most patients, again, I don't want to say for everybody, but I say in general, if you've got some underlying liver problems, then certainly talk to your doctor. But in general, it's safe. I don't think it's quite as effective, but if it works for you, great. Last couple ones, Aspercreme. Classic original Aspercreme, the active ingredient is something called trolamine salicylate, which is kind of a sister of aspirin. So it's basically like rubbing aspirin on your knee if you get the original one. I specifically, I don't know if I looked this up or I went to the drugstore, but there'll be other forms of Aspercreme with lidocaine and things like that. And I was like, okay, getting double bang for my buck. I'm getting kind of this aspirin-like thing and lidocaine to rub on your knee. The reality is you need to be very careful and look at the ingredients because the Aspercreme with lidocaine, actually it was just lidocaine, which for those of you who don't know, lidocaine is just a numbing agent. It has no anti-inflammatory effect at all. So if you have questions about this, please speak to the pharmacist. If you're kind of looking at things over the counter, they're usually very knowledgeable. But again, this is another option. Again, basically kind of like the equivalent, if you get the original one, kind of like rubbing aspirin on your knee. And last but not least is one called capsaicin. I don't use this one a lot, but it is out there. Capsaicin, how it works is a little complicated, but there's something called substance P, which is kind of related to kind of pain receptors at the site of pain. And what this does is capsaicin basically kind of wears out the local pain receptors at your site of pain or injury. So when you first few times you use it, it kind of burns because you're kind of inducing kind of the little bit of pain at that site, but you're trying to wear out the nerve response. And so as you use it over time, it does seem to work in terms of kind of reducing your pain at that site, but it just works differently. I have patients that take it. I don't have patients that, a lot of patients that do it just because, again, it does burn quite a bit when you first use it, and some people can't tolerate that, but certainly another option that's safe. All right, last but not least, we'll talk about some supplements. First thing I absolutely want to say is this is not regulated by the FDA. Supplements are considered technically like a food product. It's not very tightly regulated. It's got to be really careful here. And the other thing I want to say is I'm not going to go into detail about the dosing of these products on the next page, but you can check out the Arthritis Foundation website that I've got listed here that has a lot of good information on these products and can kind of go into more detail about the research, the evidence, and kind of dosing. So classic one, a lot of you may have heard of, may not have, but it's glucosamine chondroitin. I think we used to recommend this to everybody years ago. I think it's evidence is kind of different studies showing how well it works is kind of in question. I recommend to patients if you try it for a month or two, and if it works, great. If it doesn't work, stop taking it. But even though the evidence is kind of mixed on how well it works, I do have some patients that do find benefit. And if it works for you, great. I'm happy for you. And that goes for kind of all these products up here. One of my favorites is turmeric. It's a naturally occurring kind of herb that has got pretty good anti-inflammatory effects. There have been some studies that show it may, at the right doses, it may work just as well as like ibuprofen for helping out with pain and inflammation in the knee. Again, it's very, very safe. It's a naturally occurring herb, so I do recommend that quite a bit. Avocado, soybean, or avocado soy unsaponifiables. That's a really hard word for me to say. So when I talk to patients, I usually say avocado soybean extract, but basically a combination of avocado and soybean. Again, mixed evidence, but there's some thought that it does kind of help out with pain and inflammation in the knee, and so reasonable to try. And again, coming from avocado and soybeans, overall fairly safe. Ginger is another common one that I recommend. Again, naturally occurring kind of substance. It's got some pretty good evidence, or I'll say pretty good evidence, decent evidence for kind of pain and inflammation. And then the last one of kind of the more quote unquote natural things is sesame seeds. Like I said, just a quarter cup of sesame seeds got some evidence to help out with pain and inflammation related to osteoarthritis. And so those are kind of my favorites. I did put in something called SAMe and MSM. I'm just going to use the abbreviation because I can't say the real name. These are both a little bit more complicated how they work. One of the SAMe is actually the SAMe is actually a natural occurring compound in our body, and MSM I think is more commonly comes from plant products. But both of them are kind of helpful from a joint kind of health standpoint, is how they're kind of marketed. I think there's maybe some evidence here that says they may help some with kind of pain. I will tell you that these two products in general tend to be more expensive. And again, I can't guarantee that, but I would say in general, I've looked at the store, these tend to be more expensive than some of these other ones, but certainly reasonable to try. And I will say too, depending on where you go, different pharmacies and places will have any number of combinations of these. I've seen some combinations of glucosamine and chondroitin and MSM, and they'll just call it, joint complex juice or whatever. Same thing with turmeric or soy or something. Maybe some mixture. But again, reasonable to try these things. Again, always talk to your doctor first or the pharmacist first. Make sure there's no interactions if you have other medicines. And again, I usually say try these things for a month or two if it's safe, and if it helps, great, keep taking it. And if it doesn't, then stop taking it, and you can try a different one to see if it helps. Last but not least, I just wanted to kind of finish up with let's see my time. Oh, good, almost done, perfect. If your pain and function, if your knee pain persists, or you're still having kind of poor function, not able to do the things you want to do, after all the stuff we talked about, that's when it's time to see your doctor. That can be your regular doctor. That can be a sports medicine specialist, non-surgical like myself or one of my colleagues. And then you also can see an actual surgeon too. I usually recommend waiting until you've kind of failed everything else before you do that. Especially if you're within a big healthcare system like UNC or Duke, the knee surgeons who would do like a knee replacement typically want to see that you've tried other things first, right? So if you come to them with knee pain for a month, they're going to look at you and say, I'm not going to replace your knee. You need to do other stuff first. And so they really want to see the patients that have kind of done a lot of other things, and then kind of say, okay, yeah, you've done this. I think your x-ray is pretty bad looking. I think you're worthy of a knee replacement. So again, out in the community, different private practices, the surgeons themselves may help and do a lot of these other kind of non-surgical options as well. But what can you expect if you go see a doctor? Like what they'll tell you to consider: prescription medication, whether that's in the form of a different anti-inflammatory or other kinds of nerve blocking agents, pain medicines, whatever. May recommend a formal physical therapy referral to an actual physical therapist, which is frequently very helpful. Again, different types of kind of fancier braces, orthotics, things like that. Whole host of different types of injections that can be done. The classic one people kind of hear about, cortisone shots, which again do help with pain and inflammation. They don't do anything to treat necessarily or fix or reverse the arthritis, but can be certainly helpful from time to time. And again, there's a whole host of other ones. There's gel injections that kind of lubricate the knee. There's a whole section of medicine used to be called regenerative medicine. Now we call it orthobiologics. And that's where there's different things regarding blood draw injections, stem cell injections, which is, like I said, a whole nother beast in and of itself. Our colleagues at the pain clinic, if you're someone who's tried a lot of things and you're still just not happy with your pain and your function, but you're not ready for a knee replacement, or there's some other reason why you can't or don't want surgery, our colleagues at the pain clinic can actually do these nerve blocks or ablations where they actually kind of inject numbing medicine. And if you have a good response, they can actually basically kind of burn these nerves that give sensation to the knee. They are just sensation nerves. They have no effect on your ability to kind of move your leg. So I don't want people to think we're causing paralysis or anything, but can be effective for some patients who kind of failed everything else. And the newest thing I'll say is, and this just kind of rolled out probably within the last week or two, is something called radiation therapy. So if you think about, typically we think about radiation for patients with, cancer of some sort, and they get radiation therapy to kind of, kill the cancer cells. But our radiation oncology department at UNC is actually kind of rolling out this kind of brand new program registry that there's some evidence that shows that kind of some very, very, very low dose radiation therapy can be really effective for patients who've had kind of some resistant pain related to osteoarthritis. And then last but not least, when the time comes, if you failed everything else, if you're at the right age and health and everything, you can talk about getting knee replacement surgery. Real quick, I couldn't help but kind of put a pitch to our clinic. I think we do all three of this. This is myself on the right. This is Dr. Kane in the middle, and Dr. Adams, who's our fellowship director, on the far left. I think we all do a really good job of this. We all practice fairly similarly in terms of, I think, doing a good job of kind of managing patients as long as we can before we kind of send them to the surgeon, if that indeed needs to happen at some point. We got two places we see patients. Kind of our true main sports medicine center these days is actually out in Durham, off Mayfair Street. It's actually off Business 15501, kind of where the big Sam's and Target is, going towards Durham. And I'm there part-time, and Dr. Adams is there full-time. And then our main kind of family medicine center on campus, which is just down from the Dean Dome, I'm there part-time, and Dr. Kane's there some as well. But again, happy to see any of y'all going forward if you're not able to manage this going on your own with the stuff we talked about today. So that's my talk. And I'm happy to take any questions, and I will check the chat right now. Let's see here. Audio, please.
Justin, I know that in the chat was a question about what is the difference between seeing you versus Emerge Ortho. And to follow up on that is, can someone just call that phone number and be able to schedule with one of the sports medicine docs?
I would say yes in general, because that's what the other good thing about seeing us is, because we're within family medicine. We are technically because we're in the family medicine department, we're technically primary care. So it should not require a referral to see us. So yeah, you should be able to call and schedule. With that said, I unfortunately, I think there's still some confusion sometimes with our scheduling and phone staff that think that you have to have a referral to see us. That's not necessarily true. It may be true on occasion with certain insurances, like sometimes, like Medicaid requires a referral from your PCP, maybe TRICARE requires a referral. So there may be some special circumstances like that, but for the most part, no, you should not need a referral to see us. The difference between seeing us and Emerge Ortho, I don't quite know how to answer that question because I think it depends. I think, Emerge Ortho is I think they do a good job. They're a big company. They're all over North and South Carolina. They mostly, I think, have surgeons. I think they do have a handful of primary care sports doctors like myself, or maybe some nurse practitioners or physician assistants who practice there. I can't, again, this is me speaking broadly, that I feel like someplace like, I think the big thing I would say is someplace like Emerge, they're a big kind of private company. And like I said, they may or may not be more pushing you towards surgery sooner. I can't say that for sure. I would just say that's kind of the trend sometimes with more private companies is kind of moving you towards surgery faster. But again, I can't say that for sure. I think that really varies, from private practice to private practice. But I'm sorry I can't answer that question better, but I don't know that there's a huge difference, but I think it kind of depends on, who you see there too. If you're seeing the surgeon or you're seeing a PA or whoever.
If someone started with UNC Ortho or went to one of the UNC Ortho prompt care clinics and they hadn't been to see you yet, will they refer to you if they see this is something that's not had non-surgical treatment before?
That's a great question. They can, but they probably won't. And the reason why is um, at Ortho, they've kind of got their kind of scheduling set up to where most of the time when patients are first going to clinic, they're not going to be seeing the knee surgeon. I kind of alluded to that earlier, but most of the time they're going to end up seeing somebody like me because Ortho has their own people like me, like non-surgical sports doctors who do a lot of injections and non-surgical management of problems. They'll probably end up seeing one of them, or like I said, Ortho has a lot of advanced practice practitioners or physician assistants, nurse practitioners who just do kind of orthopedic stuff. So a lot of times they'll see them first and they'll try to manage them as best they can. And then if they're not getting better, then they'll send them to the surgeon. So they can send them to us, but they typically don't. We end up probably seeing, I think probably, our family medicine department knows us, knows what we do in sports medicine really well. And so usually it's a lot of our own fellow faculty and residents and stuff who are referring patients to us, but we'll get some community referrals as well.
Thank you.
You're welcome.
I'll check the chat box again just to make sure that we didn't miss anything.
Doc,
Yes.
I got a question.
Okay.
Do y'all do cortisone injections in your clinic too?
Yes.
Okay, I need to make an appointment. Get me one.
Okay.
Well, two. I had to get one for each knee.
Can do.
Okay. Good. Yeah, I'll get that number off the screen and I'll call y'all guys and make that appointment.
Yeah, and Ty, if you have any issues with run into any issues in scheduling it, please let me know.
Will do. And just talking about some of the things that we went over, like the weight thing. I quit smoking. I was in a smoking program. When I quit, I gained weight big time. And now I'm taking the Wegovy and I'm losing weight, and I lost 30 pounds in the last 3 weeks.
Congratulations.
Good for you.
And the thing about it is, I can tell the difference in the pain level in my knees just by losing that little bit of weight so far.
That's fantastic. Yeah, I had, I think it was when I was in fellowship. Gosh, this was 12 years ago or something. Yeah, we had a situation like that when I was the orthopedic clinic I was at. I was seeing a guy for wrist pain. I looked at his last note from months ago, and it was the discussion about whether or not he was going to get a knee replacement. And so I kind of mentioned it to him, I was like, hey man, what happened with that? And he was like, you know what? I lost 40 pounds and my knee pain got a lot better. And I was like, oh wow, okay, great. So yeah, it does make a huge difference for patients. Because I kind of tell patients, when you think about your knee compared to your body weight, whatever body weight you carry up top, your knee feels the equivalent of like 4 times that. So any bit you take up top is, you get quadruple the effect on kind of how much force and pain you kind of feel in your knee. So I think that's a great. I'm happy for you, Ty, and hopefully I'll encourage everybody else here to kind of make steps that direction too.
Thank you all so much for joining in today. And as you know, I have been recording this, and so we will get it up on the website, the link to it. So if you know of friends, coworkers, family who would like to hear this, and it will be available to them. And just want to thank you so much, Justin. And we are fortunate that Justin will be coming back in May to do another sports related topic. So stay tuned for details on that.
Look forward to it. Thank you all so much for having me. And just to follow up on kind of Ty was asking about the injections. I was just going to say, like, that variety of injections. I don't know. Again, I don't know who all's on this talk or what people treatments had or haven't had before. But basically anything in this top kind of four right here, the medicines, therapy, bracing, injections, we can do all that stuff in our office. And again, like I said, there are a variety of different injections. The only thing we're not doing, and not a lot of people are doing it right now, are the stem cell injections, but anything else kind of fancy you read about, we're probably doing it. So again, I know this was a talk about home management stuff. I just want to make sure people are aware of that.
Yeah, I've had the gel, the rooster cone. I've had that before. That didn't work at all for me.
Yeah.
Cortisone, I backed off of it for a while because it got to the point it was only working for like a month and a half.
Yeah.
But the last time I got it, it worked for the 3-month period. So
oh, good.
I went to Emerge Ortho, I guess, right over here on off of Martin Luther King.
Yep.
And got it done, but they wanted the knee replacement, and I'm scared of the knife, so
Sure.
I did not go get it done, but I'm looking to have another injection done, so I'll
Perfect.
definitely be calling.
Perfect. Yep. Happy to see you anytime. And like I said, this I was just put for those who are still on here. Yeah, this number here that's on the screen. This is our Durham office number, but they do the majority of our scheduling for both locations. So if you'd rather get seen in Chris, I don't want to go out to Durham. I'd rather go to Chapel Hill. That's totally fine. When you call this number, they can schedule it at either location.
What's that number right offhand so I can write it down?
984-215-4780.
Okay, got it.
All right. Well,
Thanks a lot.
thank you all, and especially to you, Justin. Thank you very much.
My pleasure. Thanks so much for having me, and hope everybody, I don't know if people are watching or not. If you watch March Madness, have a good time.
Okay. Bye-bye.
All right. Bye-bye, y'all. Have a good day.